Okay. So, it should be recording now. So like I said, I'd like to touch upon these topics and themes, starting with an overview of models of OCD and the treatment of OCD, of cognitive behavioral models. I think there's a certain evolution in these models, which can help to better understand an inference-based cognitive behavioral approach to OCD. Next, I will discuss the specific conceptual basis of an inference-based approach to OCD. I will call it I CBT from here on, using the abbreviation. Then next, I will discuss the empirical support for two more people coming in. I just not sure how to do that without, oh, okay. Next, I will discuss the empirical support for the model, including the treatment outcome studies we have carried out. Then in the last section, I'll be talking about welcome to more people. I'll be talking about where we are heading, the future and the dissemination of I CBT. And I'll be making several observations about the translation of theory and research into practice. Let me see this. Okay, just locked for a second. Just to put some context to this work, this is the current team of my laboratory, where we are validating I CBT amongst many other studies pertaining to OCD, as well as other disorders related to OCD. We are funded through research grants, and presently have 2 coordinators, administrative personnel, clinicians providing treatment, clinical evaluators, and of course, the students of the lab. So it's a fairly large team, thanks to the funding we have. Just quickly as a reminder, you probably all know as clinicians, but this is the current DSM-5 definition of OCD, emphasizing the repetitiveness of thoughts and behaviors that a person feels compelled to perform. In terms of changes from DSM-4 to 5, OCD is no longer considered an anxiety disorder, but is part of a separate chapter in DSM-5. Also importantly, it's now better recognized the level of insight can differ quite a bit among those with OCD, even including no insight at all, where the lack of insight starts to approach that of a delusional disorder. Common subtypes here of OCD, which include unacceptable thoughts, contamination, fears of contamination, repeated checking, usually with obsessions about negligence and mistakes, and symmetry and ordering. There are more subtypes, but these are the major ones. So staying with the topics and themes, as mentioned earlier, I will start with an overview of cognitive behavioral models of OCD, which I think will be informative in terms of better understanding the evolution of treatments for OCD. In terms of their history, it started out with behavioral therapy as part of the behavioral revolution in clinical psychology in the 1960s. And this was also when behavioral therapy was first successfully applied to the treatment of OCD. Before this, there were no effective treatments for OCD. Then in the 1980s, a different kind of model came about. And this was mostly based on Beck's cognitive model of depression, but specifically applied to OCD. And we can call this the appraisal-based cognitive behavioral model of OCD. And then we have the inference-based cognitive behavioral therapy, which was developed primarily in the 2000s. There are other treatments, mindfulness, third wave, also cognitive behavioral treatments in a way, but these are the basic roots of inference cognitive-based therapy going back in time. So starting with the behavioral model, this model holds that symptoms of OCD are developed and maintained by a pattern of conditioning and reinforcement by carrying out compulsions. So the person experiences an obsession, like maybe my hands are contaminated, which then results in anxiety. Then in order to reduce the anxiety, the person carries out a compulsion, which gives some temporary relief, but really reinforces the frequency and intensity of the obsession. And so the cycle continues according to the behavioral model. Exposure and response prevention is the treatment based on this model, first applied to OCD all the way back in 1966 by Myers, and this seemed to work very well as a behavioral treatment for OCD. So for example, in the case of a patient with obsessions about being contaminated, the patient would purposely contaminate him or herself without engaging in any rituals. Like represented in the slide, this then increases anxiety, which according to the behavioral model should result in a habituation to that anxiety, and after multiple trials result in significantly less anxiety. More than 50 years later, still the treatment of choice, ERP, as well as many other disorders. It's an effective treatment according to most meta-analysis, and it's also relatively easy to administer. But despite this, there are limitations. It can be a difficult treatment for patients. The treatment is intended to provoke anxiety through exposure, which can be difficult to tolerate. And there are issues with adherence, treatment refusal, and dropout. Then some patients do not benefit at all. 60 to 70% improve, which sounds great, but this also implies 30 to 40% are not improving at all. And even if there is improvement, this does not mean symptoms disappear or that the person is cured. And usually residual symptoms remain, which also heightens the risk of relapse. ERP is also a non-specific treatment for OCD. It was initially developed for phobia, and OCD is not a phobia. So it sometimes can feel like a bad fit when you're dealing with OCD. And it's also a fairly common complaint that we hear from patients, which is that they feel their thoughts are not really addressed with ERP. So in the 1980s, researchers and clinicians started to consider incorporating cognitive strategies into the treatment of OCD. And initially, this was mostly done just in order to aid compliance with ERP. But later, more comprehensive theories were incorporated into the treatment of OCD. And this model is called the Appraisal-Based model of OCD, which argues that obsessions are rooted in normal thinking. Normal thinking in the sense that they originate from intrusive thoughts, that everybody has experienced at one point in their life, like being contaminated or having forgotten to lock the door. But what is different is how the person reacts to these thoughts, how these normal thoughts are appraised and interpreted is what turns them into obsessions, according to the appraisal-based model. The idea originally originated from Jack Ragman. He's a giant in the field who's been extremely influential in cognitive thinking of OCD. If you didn't know, he passed away a few months ago, and actually was the clinical mentor of my mentor, Kieran O'Connor, during his time at the Institute of Psychiatry in London. And Kieran O'Connor is the person who originally conceptualized inference-based cognitive therapy. This is the appraisal-based model of OCD. No longer is it just behavior reinforcing obsessions, but whether or not a person engages in obsessions or compulsions all depends on how the intrusion is appraised, which then gives rise to anxiety and compulsive behaviors. So in terms of treatment, because the thought itself is considered normal, challenging the content of the initial thoughts or obsessional intrusion is generally discouraged. Instead, the treatment is primarily focused on modifying appraisals or the reactions to thoughts, not the thoughts themselves, like in the example mentioned here. If I have left the door unlocked, then I might be robbed. What is addressed there with appraisal-based therapy is the then, what comes after the then. Also, cognitive restructuring is often added to the treatment, targeting specific beliefs that may give rise to dysfunctional appraisals, like over-responsibility or intolerance to uncertainty, which I understand you hear a lot from in the US, the intolerance of uncertainty concept. On the European side, it's a little bit more the over-responsibility that dominates, I think. In terms of its effectiveness, similarly effective as ERP, but it does not seem to provide any additional benefit as compared to ERP alone. It's also usually delivered as an adjunct to ERP, not as a standalone treatment. And so the same limitations of ERP apply in terms of adherence, dropout, and the anxiety caused by the treatment. And similar to ERP, not everybody benefits, especially those with low insight and high levels of override ideation. Also, with respect to the belief domains and appraisals, like intolerance or uncertainty and responsibility, all these different belief domains that were developed at a time by the Obsessive Compulsive Working Group, empirical findings have been very mixed as to whether it's characteristic of OCD or not. In some contexts, non-clinical controls actually score higher on some of these beliefs than those with OCD. So they don't seem to be specific to OCD. So these limitations led to criticism by Karen O'Connor, myself, and others. And there are several points of contention, but the principal criticism is that intrusive thoughts are treated as random, neutral, and isolated events in appraisal-based models of OCD, when in reality they are still part of information processing. And so there needs to be a cognitive account why these thoughts arise in the first place. And they need to be addressed in treatment instead of being ignored, more than just saying that they are normal. And this is what brings me to I CBT, which essentially doubles down on the role of cognition in OCD in comparison with appraisal-based models, which only go halfway in this respect. According to this approach, obsessions are not rooted in normal thinking, nor do they find their origin in random intrusive thoughts. Instead, the model argues that obsessions are inferences or ideas that arise out of dysfunctional reasoning. They do not arise randomly. And this can occur with varying beliefs, varying levels of beliefs and conviction. Sometimes as a very persistent doubt, but also at times as an idea that comes close to a delusion, reflecting the varying levels of insight in OCD. Whether experienced as a doubt or as a fixed idea, they are always false inferences because they are preceded by dysfunctional reasoning. So they are abnormal to start with, not normal. This reasoning is characterized by what is called, or what we call inferential confusion, where a person gives credibility to possibilities that are not based on direct evidence or sensory input from one's immediate environment, internal and external, which is not how we reason under normal circumstances. And finally, according to the model, what makes the person vulnerable to obsessions are vulnerable self-themes and feared self-perceptions, areas of life where the person does not trust him or herself fully. So to illustrate this graphically, here's the basic inference-based model, which, as you can see, focuses on the central question of where the obsession comes from. And even though appraisals are considered important and part of the model, they are not what leads to obsessions. Instead, the obsessions are what are called inferences of doubt in OCD, in IBCT, originate from the inner circle, which is the vulnerable self-theme, feared self-perceptions, a reasoning narrative, and dysfunctional reasoning in that narrative. You can summarize it like this, with each of the different models having a primary treatment target. It's not to say that you cannot combine these treatments, we can talk about it later, but these are the principal targets of each treatment. ERP is primarily focused on anxiety and the compulsion to break the obsessional cycle. ACBT, or appraisal-based therapy, is focused on the consequence and appraisals of the intrusion or the obsession. And I CBT focuses primarily on the obsessional doubt or inference based on the idea that if you change the obsession or the obsessional doubt, then naturally will also change everything else that follows from it, including consequences, anxiety, and compulsions. This is just some main aspects of the treatment I wanted to mention here. Like I said, obviously there's a lot more to say. There's the book you see in the top right corner where the treatment is described in detail. That's the basic treatment manual that we wrote. It's primarily a cognitive approach without exposure, that is focused on diminishing the strength of the obsession by showing the client that obsessions are not based on valid reasoning. And we have developed multiple techniques and strategies for doing so, which includes teaching clients to tell the difference between normal and obsessional doubt, highlighting the selectivity of the obsessional doubt, identifying different reasoning errors in their obsessional narrative, and exploring more reality-based narrative in situations that might trigger obsessional doubts. I should probably mention here, which I don't have in the slide, it's not so much about a matter of challenging ideas like you do in an appraisal-based model. It's more like being able to provide resolution to the obsessional doubt by providing insight into the process that it comes about, which is a process that should not lead to giving these obsessional doubts any credibility. Also, the target targets fit self-perceptions, which is a common concern among those with OCD, and we try to help clients get back in touch with their authentic and real self during treatment. So in terms of empirical support for the model, I will highlight a selection of studies that are most relevant here, given the time. First, the construct of inferential confusion itself. First empirical study dates all the way back to the late 1990s, which showed it to be a type of reasoning that accounted for a very substantial amount of variance in the prediction of OCD symptoms, independent from other variables. So it seemed to be measuring something new that was specifically relevant to OCD. This was actually during my master's thesis in the Netherlands, which I did with Academy Professor, one person calling in, which I did with Academy Professor Paul Amelkamp, who was the first researcher in the world to compare behavioral treatments with cognitive therapy using rational emotive therapy at the time. And it was in 1988, I believe. But this study, we also included obsessive beliefs since we had access at the time. This was at a time that the OCD working group was having regular meetings, and we had access to the items of the obsessive compulsive working group at the time. And we wanted to administer that with no clinical controls. And I thought, why not include some items representing inferential confusion at the time? And that turned out to do quite well, these items. And this was a few years before the obsessive beliefs questionnaire was published, which was in 2001. Even though inferential confusion did quite well, it never was actually included as part of the obsessive beliefs questionnaire. And we sort of ended up with very mixed findings since then in terms of the questionnaire, of the obsessive beliefs questionnaire, as far as these specific cognitive domains and traits. But I thought, like, let's follow up on the evidence of inferential confusion. And we continued with studies after this, including using different measures of inferential confusion to obtain converging evidence for this relationship using different methods. For example, Kelvin Wong developed a task-based measure of inferential confusion, which has been further expanded by Louis-Philippe Barabi. Then another line of research has been conducted through the doctoral work of Julien and Jean-Sébastien Audet, which has shown that obsessions often occur without direct evidence for the reality. Well, this is not the case for normal intrusive cognitions. So this provides both support for the notion of inferential confusion, as well as support for the inequivalency of obsessions and intrusions. They do not seem to arise in the same way. Then another line of research is whether inferential confusion is characteristic of those with OCD. And quite consistently, inferential confusion is significantly elevated among those with OCD, both in comparison to non-clinical controls as well as anxious and depressed groups. So it seems to be a process more relevant to OCD than anxiety and depressive disorders. And again, this was established with different methodologies and measures of inferential confusion, including a recent task-based measure of inferential confusion. And also interestingly, as shown in the figure here, those with delusional disorder seem to score as high on inferential confusion as those with OCD. And this makes sense from an inference-based perspective, not from a model that assumes OCD is an anxiety disorder, but it makes sense from an inference-based perspective that views obsessions as an inference or an idea that is based in the imagination and goes against reality. So as a clinician, if you ever thought to yourself that OCD seems a lot harder to treat than a phobia or an anxiety disorder, this might be the reason. Then a third line of research that we have conducted is by experimentally manipulating inferential confusion. In one of these studies, we provided patients with possibility-based information to make them doubt reality. And those with OCD were significantly more affected by this information, which in turn related significantly to symptoms of OCD. Then in another study, we actually trained people to get better in inferential confusion. So they were trained to reason dysfunctionally. This was done through cognitive bias modification, which is usually a procedure to train people in healthier reasoning. Here it was the opposite, and this led to an increased endorsement in dysfunctional reasoning, as well as symptoms of OCD. And this study was conducted by Dr. Wong. So we have some preliminary evidence here that inferential confusion might actually directly cause symptoms of OCD. Then another important line of research, which focuses on mechanisms of change. It's important because psychotherapy research is not just about outcome in general, but also very much about what predicts these outcomes. So what we found in several studies with respect to inferential confusion was that the treatment produced significant improvement in reasoning, again, using different measures of inferential confusion, including our experimental and task-based measures. Also, reductions in inferential confusion predicts treatment outcomes. So inferential confusion is an important mechanism of treatment change. And we have established these are different outcome measures. So that's converging evidence across different methodologies. I also wanted to say a little bit about vulnerable self-themes and feared self-perceptions in OCD, which a lot of our empirical research has focused on recently. As I mentioned earlier, this is an important part of I CBT. In the figure here, you see how I conceptualized it originally. An obsessional sense of self is characterized by a feared possible self that stands at the foreground of awareness, whereas in the case of a normal sense of self, the feared self is just a possibility somewhere in the background, but not really giving too much importance or taken too seriously. And empirical research from our laboratory and others has supported this in several studies, which is that feared self perceptions about one's dangerousness and immorality predict symptoms of OCD. And this was confirmed in clinical samples controlled for anxiety and depression. Then in another study, we found that OCD patients with repugnant obsessions got higher than any other group on feared self-perceptions. So fear of self is characteristic of this subgroup of patients, but perhaps more of a vulnerability factor in others. And we also looked at how feared self-perceptions changed in the course of psychotherapy. And this study showed that improvements in feared self-perceptions predicted improvements in both repugnant obsessions and contamination symptoms. And finally, we recently completed an experimental study directly manipulating feared self-perceptions among those with OCD, temporarily increasing a fear of who they might be. And this led to an immediate increase in the intensity of obsessions. There were all kinds of precautions we took around this ethically, with psychologists available, and it was a temporary increase. And it was experienced as educational, actually, by patients. So bringing all this together, what this research has led to is an extended cognitive behavioral model of OCD that incorporates the role of both feared self-perceptions and inferential confusion in OCD. A fear of self is conceptualized here as not only influencing the interpretation of obsessional intrusions, but also the occurrence of obsessions in specific vulnerable self-themes. Also represented in the model is where a fear of self itself might originate from. The most important factor, we believe, is inferential confusion. And this goes back to the idea that there's not any actual basis in reality for the fear itself. It is imagined, at least when it comes to OCD. Another factor might be a vulnerable or incoherent self-identity to start with, similar to the notion of self-ambivalence, which is especially likely to arise during critical time periods and disruption in identity, like during adolescence, which is the usual time of onset for OCD, but also later on, parenthood, postpartum. And we published this extended model in the editorial of a special issue that came out last year. If you're interested, this issue contains a lot of research on the role of both feared self-perceptions and inferential confusion in OCD, which are both addressed explicitly in I CBT. So with all of this, there's the actual treatment outcome studies that we have been carrying out, which is the validation of I CBT in practice. First scale randomized controlled trial was published in 2004, which showed it to be an effective treatment. And despite the fact that the treatment did not include ERP, it was similarly effective to both ERP and standard cognitive behavioral treatment, appraisal-based CBT. So this showed that it was possible to get the same effects with a cognitive treatment alone and without having to provoke anxiety in patients. Also, I CBT was significantly more effective among those with higher levels of overfired ideation or those who have a high obsessional conviction. So the treatment seemed to work particularly well for this group, and this was confirmed in an open trial that showed equal effectiveness of I CBT, whether or not the person had overfired ideation, which normally is a negative predictor for treatment outcome. Other researchers picked up on this, and a multi-center randomized controlled trial was conducted in the Netherlands by Dr. Henny Visser, which also found I CBT to be more effective for those with high levels of overfired ideation. All post-hoc analysis, but it looked promising in that I CBT was at least as effective as ERP and likely more effective for subgroups of OCD patients. And presently, we have 3 recent or ongoing randomized controlled trials investigating I CBT. First one has recently been completed in Montreal and Ottawa, which is a multi-center trial and soon to be submitted for publication. A trial compared I CBT with standard CBT and mindfulness. Again, we see a similar effectiveness with standard CBT, but also interestingly, mindfulness worked quite well in the treatment of OCD. And this is actually the first RCT, to my knowledge anyways, where mindfulness was compared to other treatments. So that's very interesting. We're still analyzing all the outcome measures, but there's some indication that I CBT may work more consistently across symptoms, but also may work faster with higher rates of remissions at mid-treatment. But overall, the treatment effectiveness seems to be the same. And finally, the third RCT that is currently ongoing is also it's carried out in the Netherlands, also again led by Dr. Visser. This is a non-inferiority trial as well, but it compares I CBT with standard CBT. It also has an interesting aim to identify the neural signature in patients through MRI and to predict which treatment is the most suitable and effective for patients in a move towards a more personalized approach to the treatment of OCD. And I see I forgot to mention our ongoing non-inferiority trial as well, where we have the a priori hypothesis that I CBT is more tolerable and acceptable than other treatments and more effective for subgroups of OCD patients. So in terms of conclusions and in the future, we're starting to move beyond the typical randomized controlled trial that tries to establish superiority, which may not always be the right approach, at least not in my view. You may be aware of an ongoing debate in psychotherapy research, which is that all psychological treatments have an equal effectiveness. and that treatment outcome research is therefore extinct, like the dodo bird. On the slide, you see an interesting article on the topic. The main point here is that psychotherapy research is often very focused on diagnosis and type of treatment as independent variables, which are not easily controlled for, even in RCT. And what perhaps we should be investigating are more psychological and social factors in specific client groups that affect the efficacy of treatment. And recognize that some treatments may work better for some people, and other treatments may work better for other people. And this brings me to the specific advantages of ICBT and the questions we are trying to address with it, which is that ICBT may have a number of benefits over other treatments, even if not superior in any direct comparison for OCD in general. One is that it may work faster than other treatments. Another is that ICBT does not include exposure and tolerating anxiety. This may make it more acceptable and tolerable for some patients. And this may also mean less treatment refusal and dropout, which increases the number of people with OCD successfully treated, especially in regular clinical practice, where many seem to refuse ERP. And perhaps more importantly, is that ICBT appears to be more effective than other treatments if you go beyond diagnosis alone and consider subgroups of people with OCD that are resistant to current treatments. So given these benefits, ICBT has the potential to increase the number of patients that benefit from psychological treatments for OCD. And this could be substantial given treatment refusal, dropout, and the prevalence of treatment-resistant OCD. So in terms of future, we're looking into novel research designs that would show these benefits, while also incorporating stepped care and personalized medicine into these designs. Here you see a design that we are planning to pilot soon, which consists of a run-in treatment with exposure in vivo, only after which a subgroup, those who did not respond to ERP, are randomly assigned to more specialized treatments. And what we are trying to find out here is whether or not any further improvement is possible with these more specialized treatments after a client has received exposure in vivo that did not work, which is a situation that often naturally occurs in the real world. So it's a stepped care approach in both research design and eventually practice, but also one of personalized medicine with more specialized and scarcer resources becoming available once existing standard treatments do not work. And given the evidence we have so far, we hypothesize that ICBT is particularly well suited for patients that fail to respond to existing treatments. And finally, to conclude the presentation, some thoughts on the dissemination of ICBT. And this applies to any new treatment, I think, which is that if you develop a new evidence-based treatment that works and is viable, it still has to find its way to clinicians in the field. And that means having to go beyond traditional knowledge translation activities. That includes workshops and trainings, which we like to see a lot more of, since the interest is there. In our experience, what is also extremely important are published treatment manuals, so that interested clinicians can educate themselves on the approach, and we published 2 of those. Also, a self-help manual is something I am working on, which brings the treatment directly to those suffering from OCD, but I think it will be very helpful for clinicians as well. Then another initiative we have is online resources, including information for the public, where to find an ICBT therapist. This is a work in progress, and we'll be updating the site more in the future. And finally, an initiative that we recently started, which some of you may be aware of if you joined it, is to bring together practitioners interested in ICBT in an online group, Facebook group, for mutual support and advice in the treatment approach. So these are some of the main initiatives we have beyond traditional knowledge translation. But clearly it has to be a joint effort, and hopefully an increasing the amount of people help with the dissemination of IBCT to make this treatment more available for those with OCD. Merci. This is the end of the presentation. If you want to know more of our recent and current activities at the lab, we just published a magazine and you can download it at our institute website shown here. Thank you. Let me stop this share here for any questions, or maybe we can discuss any questions you have or comments or things you'd like to discuss. Well, let me stop the recording as well.